Hey everyone, welcome to another EM Docs videocast. And today we're looking at some EBM updates specifically for inhaled steroids in patients with asthma. Asthma is incredibly common. There are millions of ED visits every year for asthma, and those visits may range from anything as simple as a medication refill all the way to that patient with severe respiratory distress. Now, our treatments are geared towards reducing that airway hyperreactivity, the bronchoconstriction, the inflammation. That means we give the patients inhaled beta agonists, inhaled anticholinergics, and also steroids. But what about inhaled steroids? Well, inhaled steroids are a key component of the outpatient management for these patients. They can reduce airway inflammation, they can reduce the need for healthcare visits, and they improve sensitivity to beta agonists. Plus, they're a key component of guidelines. But I'm getting ahead of myself. Let's get to study number 1. Inhaled corticosteroids rarely prescribed at emergency department discharge despite low rates of follow-up care. This was published in Journal of Emergency Medicine, May 2023. The primary question from this study was in adult patients with asthma discharged from the ED, what are the prescription rates for inhaled steroids? This was a descriptive, retrospective chart review of adult patients who came to the ED due to asthma over a 2-year period. It was conducted in 5 urban academic EDs, and they looked at attending charts. They excluded patients who were admitted, transferred, or who died during their ED visit. They also excluded patients who were already on an outpatient inhaled steroid. The primary outcome was the proportion of patients discharged with a prescription for an inhaled steroid from the ED. They also utilized multivariate regression to evaluate some other predictors of who received an inhaled steroid. Let's get to the results. There were over 4,000 ED visits for asthma during this time period. They selected a chart sample of 150 charts. Overall, they found that inhaled steroids were prescribed in 6% of patients. They also found that patients who received inhaled steroids in the ED during treatment and those who received a prescription for a beta agonist were more likely to receive an inhaled steroid prescription. There was decreased odds of receiving an inhaled steroid in patients who are Hispanic ethnicity, Black race, and private or no insurance. When you look at follow-up and primary care, there were some other issues. 14% of patients had follow-up within 30 days, and there was a 4% ED revisit rate also within 30 days. Only half had a primary care doctor, and only 21% followed up with that primary care provider within 30 days. Now, there are some limitations and considerations. First, there is limited evidence looking at what we do from the ED setting when it comes to using inhaled steroids. Second, this was one system and it was urban academic EDs, both of which potentially limit the generalizability. This was focused on attending EM doc charts, and it was chart review, observational methods, obviously subject to confounders and risk of bias. Now, I had mentioned guidelines earlier. What do the guidelines actually say when it comes to using inhaled steroids? The Global Initiative for Asthma released updated guidelines in 2023. Now, if you get the chance, these guidelines are great to take a look at. Not only do they talk about the ED management, but they look at the long-term outpatient therapies for these patients. And they divide that outpatient management into 2 different tracks. Track 1 is to start with a low-dose inhaled steroid plus formoterol, and then there's a progression from there. Track 2 is to start with an inhaled steroid whenever a short-acting beta agonist is taken, and then there's a progression to a low-dose maintenance inhaled steroid. Now, as you can see, an inhaled steroid is a key component of both tracks, so obviously it's an important therapy. Now, you might be asking yourself, should I be prescribing an inhaled steroid for these patients from the ED? Well, I'm a big proponent of this. First, if they're in the ED with an acute asthma exacerbation, that probably means their disease is not well controlled. We know that inhaled steroids can improve their symptom control and it can reduce the need for healthcare visits. You can have a major impact on the lives of these patients by prescribing an inhaled steroid. Next, what about cost? I've heard that inhaled steroids can be expensive. Well, albuterol is about 17 bucks for a single inhaler. That combination inhaler of budesonide plus formoterol is $100, much more expensive. But if you look at budesonide, single inhaler out of pocket is about 40 bucks. So instead of prescribing that combination inhaler, I like to give the patient two separate inhalers, budesonide plus albuterol. Finally, what about complications and side effects? There are almost no systemic side effects or adverse events from inhaled steroids. Patients can have dysphonia, thrush, contact dermatitis after using an inhaled steroid, but almost all of those can be prevented by having the patient swish and spit after using the inhaled steroid. The bottom line, inhaled steroids are prescribed in less than 10% of patients discharged from the ED after an asthma exacerbation. Inhaled steroids are a key component of chronic outpatient therapy. They improve long term symptom control and reduce exacerbations and the need for healthcare visits. Let's get to paper number 2, Inhaled Corticosteroids in Acute Asthma, a systematic review and meta-analysis published in Journal of Allergy and Clinical Immunology in Practice, February 2020. The primary objective of this meta-analysis was to evaluate the efficacy of inhaled steroids in ED patients with moderate or severe asthma exacerbation. They included RCTs looking at inhaled steroids plus systemic steroids versus systemic steroids alone as a primary comparison. Ultimately, authors included 25 studies with over 2,700 patients. They found that the combination of inhaled steroids plus systemic steroids reduced the risk of hospital admission when compared with systemic steroids alone, with an odds ratio of 0.73. Now, this is an interesting question. Many of us are not incorporating inhaled steroids in patients with acute asthma while they're in the ED. It's also an important outcome with hospital admission. Unfortunately, there was a lot of heterogeneity among the included studies, especially dosing of the inhaled steroid. It ranged from anywhere between less than 1,000 micrograms all the way to over 3,000 micrograms of an inhaled steroid. Also, unfortunately, the individual studies did not do a good job of reporting adverse events. Bottom line, high doses of inhaled steroids added to systemic steroids may reduce hospital admission in patients with moderate to severe asthma exacerbation. I'm not doing this for all my patients, but if I have a patient who I've given Duanebs to, they've received systemic steroids, magnesium, fluids, then yeah, I'm going to pull the trigger on using high-dose inhaled steroids. Thanks for joining us on today's videocast. Until next time.